Good evening. Thanks to each and every one of you for joining us today. My name is Ankit Dogra. I, along with my teammates, Dr. Deepika Chhabra, Mr. Arvind Singh, and Mr. Amit Saxena from Medical Services Jagsonpal Pharmaceuticals Ltd, are very pleased to welcome you all to today's webinar on optimizing nutrition and mental health of adolescents, organized by Sir Gangaram Hospital under the aegis of Adolescent Committee AOGD, with academic partner Jagsonpal Pharmaceuticals Ltd, makers of LycoRed Cell Protector, soft gels of lycopene, zinc, and selenium. We also present CycloReg CR10 controlled release tablets of 10 mg northestrone acetate and Cystelia-M, formulated with the ideal 40:1 ratio of myoinositol and D-chiroinositol with folate and vitamin D3 for the management of PCOS and related infertility. Dear attendees, if you have any questions, suggestions, or clarifications, please post them in the Q&A box. Please note this webinar is streaming live on the Facebook and the link is shared in the chat box. Also note, for the future reference, this webinar will be uploaded to our YouTube channel, Jagsonpal Medical Insights. Now, let us welcome the conveners of the program, Dr. Mala Srivastava, Past President AOGD, and Dr. Anita Rajorhia, Chairperson Adolescent Committee AOGD. And I invite Dr. Mala Srivastava to kindly initiate the program. Over to you, ma'am.
Thanks. Good evening, everyone. It's my pleasure and privilege to conduct this webinar on optimizing nutrition and mental health of adolescents, organized by Sir Gangaram Hospital under aegis of Adolescent Committee of AOGD. Dr. Anita Rajorhia, who is also the co-convener of this webinar, she is the chairperson of the Adolescent Committee of AOGD. Our adolescents are our future. We have to take care of their physical and mental health so that they grow into healthy and responsible adults in the future. May I have Dr. Anita Rajorhia's CV so that I can introduce her fully to the audience. Dr. Anita Rajorhia is a very vibrant chairperson of the Adolescent Committee of AOGD with present affiliation to Asia-Oceania Federation of Obs and Gynae and lots of societies like IMA, DMA, AMWI, ISAR, ISPAT, etc. Major achievements: founder, Vice President, Delhi Gynae Forum Southwest, past Chairperson, Reproductive Endocrinology Committee, member of Reproductive Endocrinology Committee and Infertility Committee of FOF, member of Endocrinology Committee, Breast Committee, Food and Drug Committee and Family Welfare Committee of FOXI. She has been very active in all the programs of FOXI as well as AOGD. And I would like to invite our chief guest for this webinar, Dr. Achala Bhatta. Dr. Achala Bhatta is a professor at Department of Obs and Gynae, VMMC and Safdarjung Hospital. She is the president of AOGD. She has been president of NARCHI Delhi chapter 2018 to 20, chairperson Urogynae Committee of AOGD, chairperson Rural Health Committee of AOGD, honorary secretary of AOGD in 2015-16, ex-editor AOGD, ex-editor NARCHI. She has been coordinator for many programs of FOXI as well as AOGD, a dedicated teacher and great academician. It's my pleasure and privilege to invite our chief guest for the evening, Dr. Achala Bhatta, for her pearls of wisdom. Over to you, Dr. Achala.
Thank you, Mala, and thank you, Anita. I think today's program is really good because we do need to look after the health of the adolescent who are the pillars of a nation. Nation is built from the youngsters only. How they grow, how is their health, how is their physical health, how is their mental health. And I can see you've got gathered faculty from all over India for this webinar. So we will have, inputs from all over the nation in this program. They have there as expert chairpersons for all the three sessions. I can see people from many places. And endocrinology in adolescent is, of course, a very important aspect because transition have a lot of problems in that. So everybody needs to be aware. As such, adolescents have mental health problems because of the transition from one phase of life to another. Thus, this COVID era has increased those mental problems. Earlier also, Anita had done a problem on the webinar on the mental health of adolescent, and I think it's a very good initiative to do such programs, and I'm sure everybody is going to take away very good take-home messages. And thank you for.
Thank you, Achla ma'am. Thank you for those words of wisdom. Now it is my proud privilege to invite my another guest of honor, Dr. Kanwal Gujral, for her words of wisdom. We all know respected Kanwal ma'am. She's the chairperson of Institute of OBGYN at Sir Ganga Ram Hospital, New Delhi. She is in charge of high-risk pregnancy clinic there, has been past president NARSHI, vice president AOGD NARSHI, then joint secretary Indian Menopause Society, vice president NARSHI, and she has been past editor of Journal of Fetal Medicine India. And DGF Central, she had chaired in as past president, and she is now advisor to DGF Central and President Society of Fetal Medicine Delhi chapter. She is currently there as chair of that and member editorial board working group, current medicine research and practice. She has published various papers, chapters, contributed chapters in books, and delivered so many guest lectures, national and international conferences. As far as I know, ma'am, she's a very well-read, very knowledgeable faculty. We are really, ma'am, honored by your presence, and I invite you for your words of wisdom.
Thank you, Anita. You're always very kind, very elaborate with your words. Thank you for that. And as the chief guest, Achla, said, that in the adolescents are the pillars of society. And when you see the quantum we have, India has the largest adolescent population, 19.6% of the world's adolescent population. In numbers, we are 253 adolescent, and one in every 10th or 9th is an adolescent girl. So that is where we got to concentrate. One in 9th or 10th is every adolescent girl, 9 or 10 Indian, I mean. 70% of the adolescent population lives in the villages. And as per the fact sheet of 2017, 45% of the girls between ages of 15 and 18 have a BMI less than 18.5. So there's a big chunk of undernourished adolescents. We got to look after them. Now, when we come to the other part, the cities, the urban, fortunately, the urban population of adolescent now has declined from 21.9 to 19.2% or so. But when you look at these adults, these problems of this group of urban adolescents, 11% are overweight and 4% are obese. So we have overnutrition at this part of the world, the urban part of India, overnutrition. What is the cause of overnutrition? We don't know. Is it an internet addiction, binge eating, cocalization, or they are obese, self-esteem low, and they stick to the internet? All that cause and effect, we don't know. So this issue is also going to be addressed in this seminar. Mental health is a very big problem in adolescent. 1 in 17 adolescent experiences some kind of mental health issue. which could be anxiety, depression, behavior problem, etc. And suicide is the fourth leading cause of death amongst disorders. So we really got to, look after this important part of our society so that we have a bright future for our country. This is very, very important. With those few words, all these issues are going to be discussed in detail by the learned speakers. I won't stand between you and the, faculty. With that, I wish you all a very good seminar. I've heard this seminar before. It is excellent. Those who've not heard it, they must hear it again. That is it. Thank you, Anita and Mala.
Thank you, ma'am. Thank you for those pearls of wisdom, ma'am. And I'm really grateful to ICOG also. They have given us 2 credit points for this. So I'm really thankful to Dr. Udayawala, Dr. Parag Viniwala, and Dr. Ashok Kumar for accrediting this webinar to ICOG credit points. So now, can we move on to the scientific session now? So I now request Dr. Renuka, our MOC for today. Dr. Renuka Brijwal is the member Urogyne Subcommittee AOGD, and she's a very active, upcoming bright future doctor. And I invite her for carrying out the academic session further. Over to you, dear Renuka.
Thank you, Anita ma'am, for kind words. Now I would like to start session 1 of today's scientific program, and to chair the session, I am inviting Dr. Kiran Arora. Ma'am is Director, Sukhmani Hospital, Sector 38, Gurugram. She is also President, Gurugram Obs-Gynae Society and Vice Chairperson, IMA, Gurugram. Dr. Deepa Mukundhan, Ma'am is Consultant Obs and Gynae and Endoscopic Surgeon at Assured Best Care Hospital, Trichy. She is also Secretary, Trichy Obs and Gynae Society and Executive Committee Member, Midlife Management Committee, FOXY. Dr. Manisha Ghate, Ma'am is Consultant in Ghate Surgical and Maternity Hospital and also Director of Chandrapur Test Tube Baby Center and Chairperson Women Dr. Wing, IMA, Chandrapur. I request Dr. Kiran Arora to please invite Dr. Shweta M. Arora, our first speaker, who is going to talk on adolescent endocrinology today. Dr. Kiran, please invite Ma'am, Dr. Shweta.
Thank you, Doctor, for your kind words. I'm thankful to the organizers to having me on board this webinar. Today, we would be discussing a very important topic close to my heart. This is adolescent health, the nutrition and mental health. So to talk on this topic, we have with us none other than Dr. Shweta Mittal Gupta. She's Senior Consultant, Center of IVF and Human Reproduction, Sir Gangaram Hospital. She's Editor, Indian Fertility Society, credited for first pregnancy from frozen thawed oocyte, North India, first fellow, National Board Reproductive Medicine. She is recipient of Economic Times Award for inspiring obstetrician gynecologists and IVF, Vigyan Vardhan Award, Foxy Ethicon Traveling Fellowship, IHW CME Excellence Dronacharya Award. She is peer reviewer of Journal of Assisted Reproduction and Genetics, Journal of Obstetric Gynecology of India. Welcome, ma'am. You may please start your talk.
Thank you very much for such kind introduction. Thank you, Dr. Mala, Dr. Anita, the Adolescent Committee of AOGD, and we hope to have many more interesting programs. I'll just share my screen. Just a second. So puberty is a vital process in the development of all individuals. It is a series of hormonal changes during puberty which results in the physical development of sexually mature adults. In addition to sexual maturity, children also go through other physical and emotional changes such as hair growth, voice changes, acne. This is the physical part. And of course, the emotional part where there are, and in fact, I think I'm dealing with one teenager right now at my home, and I can see evidently that what are the different changes, what are happening, and how in a very subtle manner and in a very diplomatic manner, these teenagers need to be, dealt with. So what sets the onset of puberty? Of course, nobody knows, but then one day, all of a sudden, very, dramatically it happens. And GnRH neurons of the hypothalamus, which control the initiation of puberty. The pulsatile GnRH secretion by these neurons is the one which causes changes of puberty. Now, the molecules which have been identified are the kisspeptin neurons, which are located in the arcuate nucleus, which release a molecule called neurokinin B and dynorphins, which will actually start the generation of the pulsatility of the GnRH. Now, we know that in the initial parts of puberty, this secretion is not very rhythmic. It is very erratic, and that is why some cycles can be anovulatory for girls, and they could have a few periods of, maybe menstrual cycle, and they could go into amenorrhea. And this whole HPO axis takes time, maybe up to 1 to 2 years to be set completely. So GnRH causes in turn the release of LH and FSH from the gonadotropic cells of the anterior pituitary. And we know that this pulsatility has to come in slowly. And also there has to be a difference in the amplitude as well as the frequency of GnRH pulsatility, which causes a selective secretion of FSH and LH in a differential manner throughout the menstrual cycle, so as to cause a perfect ovulation later and to have a regular menstrual cycle. Now, FSH and LH initially will affect in males the Leydig cells and Sertoli cells in the testis, and theca and granulosa cells of the ovary. So this is what we keep learning, the 2-cell 2-gonadotropin therapy, and we know the bandmaster is our hypothalamus, which has to keep secreting the pulsatility in a rhythmic manner. So the linear growth of puberty results from pulsatile increase in growth hormone secretion, which is very, very important in the initial part, which is secreted by the pituitary gland. It also increases the insulin-like growth factor 1, which is also required. Number 2, estrogen. So once the GnRH pulsatility starts, it will have estrogen increase, which will increase the rate of growth hormone action, which is also involved in growth plate acceleration and fusion. So estrogen not only has an action on the ovarian tissue and the endometrium, but it also has it on the growth hormone. And testosterone increases insulin-like growth factor 1 levels, and there is a burst of growth hormone secretion. So the growth hormone secretion is augmented by GnRH pulsatility, by the estrogen in the women, and by testosterone in boys. Now, what is happening besides our, GnRH pituitary ovarian axis? There is a separate mechanism by which it is working, and that is our adrenal cortex. Now, it is important because the zona reticularis of the adrenal cortex, it will be producing hormones which will be responsible for adrenarche and function separately from HPO axis. So we know that when we talk of premature puberty, there is either an increase of adrenal androgens to levels which are normally seen in early puberty, which will be early maturation of zona reticularis of the adrenal cortex, or there could be normal adrenal androgens level for the age, and there could be hypersensitivity of pilosebaceous unit to these androgens. Now, what is the average age of puberty and what is the comparison? So it is generally between 8 to 13 years of age, but what are the changes which happen in girls and boys differentially? In girls, the most notable and reliable first sign of puberty is breast development. It is usually followed by enlargement of labia majora and labia minora and a clear white vaginal discharge. The pubertal growth spurt occurs typically between 9 and 10 years. The breast development, thelarche, typically occurs anytime between 8 to 12 years, and menarche generally follows shortly after thelarche, about 2.5 years later. So if a girl is having breast bud development, then we can kind of counsel or expect that in the next 2.5 years, she will start her menarche too. It will also help the mothers to maybe counsel their daughters to sensitize them that what they are going to look forward to later in the life. So average is about 9 to 15 years with an average of 12.5 years. Now, parallel in the boys, puberty in boys will begin with testicular enlargement to greater than 2.5 centimeter in length or 4 ml in volume. The average, again, the time range is 9.5 to 14 years with an average of 11.5 years. There is pubic hair development in males, which is controlled both, which we just saw, by adrenal androgens. DHEA, DHEAS, both of them will are the well-known androgens produced by the adrenal cortex and usually occurs between 7 to 8 years. Now, these androgens will also assist in development of axillary and facial hair and voice changes. So the male growth spurt typically occurs between 11 to 12 years. So if we compare, the girls will be having the spurt a bit earlier than the boys. So if we are looking at the chronology, we are looking at adrenarche, thelarche, pubarche, menarche. In most girls, the breast development will begin before the appearance of pubic hair. But for some reason, there is a higher risk of PCOS in girls who get pubic hair development before breast development, maybe because their androgens are working more. Now, in very little 8 to 10% of individuals, 8 to 15, there could be adrenarche, pubarche, thelarche, and menarche. So this equation can change a bit in some of the patients, some of the girls. Now, pubic hair development usually follows along with breast development and occurs due to production of adrenal androgens. And we know there are two adrenal androgens, DHEA and DHEAS, which occurs by the age of 6 to 7 years, and it is independent of thelarche and menarche. So let's see the chronology. Breast spurt at 10.5 years, onset of pubic hair in this particular girl could be 11. The maximum growth spurt would be 11.5. Menarche could be achieved by say 12.5. The adult breast size is formed by about 14.5 years and adult pubic hair when she's closing to 14 years. And this is the average chronology. So if a patient or a girl comes in our OPD, how we can do the Tanner staging of pubic hair staging? So we can see that pubertal, there are the vellus hair, actually no pubic hair. In stage 2, very sparse growth, chiefly appearing along the labia. In stage 3, the hair is considerably darker, coarse, and it spreads sparsely over mons. In stage 4, it resembles more or less like adult, but there is no hair spread to the medial thigh. And when we are looking at stage 5, then hair is adult type, dark, coarse, curled, the classic female triangle, and also spreading to the medial thigh. So this helps us in categorizing when we see girls, especially when we come across amenorrhea. Now, the same way, if we want to categorize the breast development, in stage 1, only a papilla is elevated. In stage 2, you see the breast bud, areola widens, it darkens, slightly elevates, and you can see a palpable, the bud of the breast tissue is palpable below the nipple. In stage 3, the areola and breast have further developed, no separation of contour between the nipple and areola, how we can see in the diagram, and the breast tissue creates a small cone. In stage 4, of course, there is a secondary mount, and in stage 5, which is fully developed, the most mature adult type, you have a secondary mount made by areola and nipple, and by stage 4, it disappears, the nipple, the categorization, and only the papilla projects. So this is how we can, when we can keep this chart in our OPD, and we can kind of have an approximation, and when the girl comes to us or the boy, we can see and compare from this chart. Now, just few slides about precocious puberty. Now, we had a very nice talk by our fellow in the morning itself about precocious puberty, and we were debating that what should be considered. So if it is basically pubertal development, which is 2.5 standard deviation earlier than the average age for that population. So roughly we can say if secondary sexual characters develop before 8 years and menarche before 10 years, we will call it precocious puberty. But true precocious puberty is characterized by early breast and pubic hair development. So if we want to look at the causes, it is GnRH dependent, central, which could be idiopathic in 74% of cases. It could be a central nervous system problem in about 7%, or it could be peripheral, which is not dependent on GnRH analog and GnRH agonist. So that could be ovarian tumors, or any tumors, 11%. Then less common causes could be the McCune-Albright syndrome, or adrenal feminizing syndrome, adrenal masculinizing syndrome, and ectopic gonadotropin production. And then there could be incomplete precocious puberty. And we also need to know, of course, when we talk of adrenal, the congenital adrenal hyperplasia, where girls can have premature secondary sexual characters also, adrenarche followed by premature menarche. So what are the indications for evaluation? We will evaluate if less than 6 years, either there is breast or pubic hair development, it's too early. Less than 8 years, if there is both breast and pubic hair development. 6 to 8 years, only breast or pubic hair, just do individual judgment, exam findings and level of anxiety of parents and patient. Now, if there is associated headache, seizures, focal neurological deficits with rapid pubertal progression, then it is an indication for intracranial pathology and complete evaluation and imaging. So if there is, breast and pubic hair development, the algorithm is that it's very important to look at the bone age. So most commonly performed is the wrist. So if bone age is advanced, you do a GnRH agonist stimulation test. If it is normal, then again, you look at three things: breast and pubic, breast or pubic and accelerated growth, or breast. So these two are there. Again, she goes for a GnRH agonist stimulation test. If there is only breast or pubic hair, then it could be just an incomplete precocious puberty. I think just keep her under observation, and there is nothing else which we really need to do. In the stimulation test, if there is a very high basal or a stimulated LH, then we can say that there could be a gonadotropin dependent precocious puberty. Do an MRI, do the thyroid test, do an ultrasound, and do the hormones. And if there is gonadotropin independent precocious puberty, then the most important role is first of hormones, and then you can think of an ultrasound. So how to do the stimulation test? You obtain a blood sample. After 30 to 40 minutes, you administer an agonist, which is leuprolide, 20 micrograms per kg subcutaneous. After administration, do a test, LH test, after 30 to 40 minutes. Now, a stimulated serum LH of more than 5 actually defines the upper range. So if it is really high, we know it's gonadotropin dependent. So we are looking at central cause. If it is not very high after administering GnRH agonist preparation, then we know it's other peripheral causes of precocious puberty. And this is how it can help us. Now, treat the cause: thyroid replacement, neurosurgery, not getting into the details, surgical excision of masses, agonist for idiopathic cases. I will just take a slide on that. And of course, intellectual and psychological support, because sometimes the parents are very, very worried about these symptoms. So reassurance is so much important, especially when, for girls or boys as compared to their peer group, if they're having premature, pubertal development, it can cause a lot of anxiety. GnRH analogs is important for us to know, because initially, of course, they cause a flare and then they will cause reduction in gonadotropin. Important is that they will cause regression of pubertal characteristics, amenorrhea, and reduction in growth velocity. What we want is a final bone height. This is very important because a girl, the moment she starts a lot of estrogen activity, can have stunted growth. We don't want that. So the most effective treatment, if it begins, if the bone age exceeds 12 years, you must start doing that. Maintain the E2 levels less than 10, prepubertal age group range, and most effective in idiopathic precocious puberty. One word which I wanted to say, that in these subset of girls, they don't cause GnRH agonists, they don't cause bone loss, so we should not be worried about that. So prognosis, of course, the mean height what we need to achieve is 152 centimeter. Now, just 2-3 last slides about delayed puberty. Now, if in case we are dealing with absent or incomplete sexual maturation by the time 95% of children of the same sex start, so usually by the age of 12 years, then we should start, just looking into it. So delayed puberty, just general causes. If it is a true delayed puberty, so you must look at hypergonadotropic hypergonadism, that is ovarian failures. And that is the place where, comes the role of normal karyotypes. So they will normally be presenting with primary amenorrhea. So we know that 14 years and 16 years, we need to know with sexual characters and without secondary sexual characters. So how much can we wait? We can have hypogonadotropic hypogonadism. Clinically, both these categories will, present same. However, it would be at the time of puberty, which we can see, because pre-pubertal it will be very difficult. All her FSH and LH would be low. So if we are looking at hypogonadotropic hypogonadism, we are looking at reversible causes and irreversible causes. And in irreversible causes, I think in very early age group, it's very important that they should not be having a complete pituitary failure, because they will not only need growth hormone replacement, but thyroid, they would maybe need steroids, and of course later on estrogens. And then if you're looking at completely eugonadic causes, do not miss out on Mullerian agenesis, so outlet obstructions, septums, imperforate hymens. But normally they will be detected because she would be starting, menarche, and she will come with pain abdomen. So this may not be able to, you will not be missing on them. So the main function of puberty, of course, is to produce sexually mature adults. The hormonal changes of puberty allow children to become reproductively viable. Puberty is also a period of increased linear growth, and large period of an individual's height is achieved from the growth occurring in puberty. So this is what we have already seen, that when there is delayed breast or pubic development, this is what we would do. So I think very important is bone age. Then comes your role of hormones. There is a role of karyotype. There is a role of MRI. And we need to distinguish in delayed puberty that are we dealing with an ovarian failure in girls, so hypergonadotropic in both the sexes, or we are dealing with hypogonadotropic hypogonadism. So again, the management is correction of primary etiology. And we are not going into the gonadal dysgenesis, and hormone replacement therapy if we have diagnosed type 1 or type 3. So thank you so much for patient hearing. And I think earlier, I'm sure Dr. Gujral and would have seen many cases of precocious puberty and delayed puberty. Many of them, they go to pediatric endocrinologists nowadays. But I think we need to have a sound knowledge that how we will work them up and when they need what kind of referral.
Thank you, Dr. Shweta. Over to chairpersons for their expert comments.
Good evening, and thank you so much, first of all, AOGD, Dr. Anita and Dr. Mala Srivastava for having me on this on board this wonderful CME. Actually, very lovely topics. I must congratulate Dr. Shweta for that excellent presentation. I think endocrinology, adolescent endocrinology is like more or less mathematics. It is complex, and you made it so simple, and it was a very clear presentation. Congratulations. I really loved your slides, and I think what we all need to know is we also need some emotional support for both for the child as well as the parents whenever we come across precocious as well as delayed puberty, because these people, especially the parents, can be super anxious. So a lot of emotional support is what is required for them to either it is for reassurance or for treatment or whatever. So that was an excellent presentation. Congratulations. Over to the other chairpersons for their comments.
Dr. Kiran, Dr. Manisha.
Thank you, Dr. Shweta, for a wonderful presentation. Adolescent age is dicey for all parents we've gone through. So adolescent being the future of our society and the future of our nation, we really have to care for them. And now, of course, these days we are having adolescent clinics and we are caring for them. Earlier, they were a neglected lot of the society. So that thing we are covering up. And with these lectures and seminars, we are all becoming more and more, oriented to care for our adolescents. Important is to recognize their problems and address the problems. It may be short stature or very, tall or increasing height very fast. It may be puberty disorders, maybe precocious or delayed puberty. It may be, those aggression and anger and social maladjustment, depression, anxiety. All these things need to be cared for. And we shouldn't shy away from referring them to a psychiatrist, to an endocrinologist, and take timely action. More important is to give tender loving care, explain to the family, explain to the child, and things work out. So we also have to be, tuned, trained, and more oriented to help the adolescents of our society. That's from my side.
Dr. Manisha, your comments?
Yes. First of all, thank you to all the organizers for giving me this opportunity. I agree with Dr. Kiran Madam and Dr. Deepa Ma'am. Adolescent endocrinology, it is a very vast topic, and Dr. Shweta Madam has very precisely elaborated the topic and simplified it. The flow charts which she presented of especially precocious puberty, delayed puberty and all, they were all self-explainable, and appreciate the madam's effort for giving this lecture and enlightening to all our delegates here today. I think, madam, a big thank you to all for sharing your presentation with us. It was such a lovely presentation. And with the request of the organizers, I thank you all once again for giving me this opportunity. Can I share my appeal? Yes.
Yes, definitely.
Yes. Thank you once again. And good evening to all my respected seniors and dear friends. At the outset, myself, Dr. Manisha Ghate from Chandrapur, Maharashtra, I will request you to all to support me, nominate me for the newly formed Violence Against Committee, that is the WOW Committee, No to Violence Against Women's Committee. I have been working for the same cause since last 12 years, and that too at the ground level. Our project of Surakshiti in Marathi, meaning Surakshit Wo, which has been awarded by National IMA as the best project in 2019. And we are continuously working under this project for the upbringing of our women of the society. So it is my humble request to please support me and vote for me from your society. Thank you, and please take care.
Dr. Manisha, very aptly, you have come at the right time, because these precocious puberty children are also very much exposed to
very liable.
sexual violence also, because they are very prone. That is another social implication.
Yes. And
best wishes to you.
Yes, ma'am. Thank you. And to you
Best
also,
wishes
Mala Madam
to,
and Anita Madam. Thank you. Thank you for the opportunity.
Okay. Thank you. Thanks, Dr. Manisha.
Yes.
Dr. Renuka, you can go for the second one.
Thank you, Dr. Kiran, Dr. Deepa, and Dr. Manisha for joining us today and for sharing your valuable expert comments with us. And I congratulate Dr. Shweta for her brilliant presentation. Now moving on to session 2. For this session, I would like to invite Dr. Amita Gupta. Ma'am is a senior consultant at Amita Maternity Hospital, Palwal, and she is also President, Palwal Ops and Gynae Society. Dr. Suman Sinha, ma'am is Senior Consultant Ops and Gynae at IVF and Infertility Center, Ranchi, and also Director, Advanced Care and Maternity Center, Ranchi. She is also President, Ranchi Ops and Gynae Society and East Zone Coordinate Medical Disorder and Pregnancy Committee, FOXY. She has invited as faculty in many national and international conferences. Dr. Chanchal Gupta, ma'am is head of the department and senior consultant ops in minimal invasive gynae surgery at Asian Fidelis Multi-Speciality Hospital, Faridabad. She is secretary Faridabad Ops and Gynae Society and faculty, and she has been faculty at various national conferences and authors of various publications. I request Dr. Amita Gupta to please invite our speaker.
Good evening, everyone. Thank you, Renuka, for giving me this opportunity, and thank you, AOGD Organizing Committee, especially Dr. Mala and Dr. Anita, for giving me this very prestigious opportunity. And now I take my opportunity to introduce our speaker of today, Ms. Kanchan Sandhi. She is working as a dietitian in Sir Ganga Ram Hospital from 15 years with total experience of 20 years. Before Ganga Ram Hospital, she has also worked in Delhi Heart and Lung Institute as a senior dietitian. She excels in various therapeutic diets like diabetes, heart disease, child nutrition, ketogenic diet, metabolic disorders. She is life member of Indian Dietetic Association, Delhi chapter as well, Delhi Dietetic Association. So the floor is yours, Ms. Kanchan Sandhi. We are eager to hear from you. and your
Thank you so much,
wisdom.
ma'am. Thank you so much. Am I audible?
Yes, you are.
Okay. I'm feeling very much honored that I have got the opportunity to speak in front of you, all the seniors. And I really thank Dr. Mala for inviting me this webinar. So I'm sharing my screen. So today I'm covering the topic of nutrition in adolescence. It is the second decade of life for every child. So adolescence is the transitional stage of development that bridges the gap between the childhood and adulthood. It is characterized by physical growth, reproductive maturation, cognitive development. The stages of adolescence, as we all know, it is early adolescence, middle adolescence, and late adolescence. And it is divided into different years, like early adolescence is 12 to 14 years, middle adolescence is 14 to 17 years, and the late adolescence is 18 to 21 years. So the most important part is why they need good nutrition, because there is a greater demand for the nutrition. Why there is a greater demand for nutrition? Because there are development changes that are occurring in the full swing. There are changes in the lifestyle. There are changes in the eating behaviors. There are changes in the psychological changes are there, which are occurring due to the peer pressure, due to the generation gap between the parents as well as children. And poor nutrition, they can lead to two things. Either undernutrition will occur and micronutrition, which can cause PEM, and overnutrition, which can be seen in urban cities, that can lead to obesity. Now, there are changes in dietary pattern. There is a risk of taking restricted calories. Increased intake of junk food is there because peer pressure is there, internet is there. So the children are more prone to take junk foods because they are easy to eat. They are easily available these days. Consuming unbalanced and high-fat diets. All junk foods are high-fat. They are skipping meals, maybe because of the studies or maybe because of like online classes. They are skipping meals also. Fewer intake of protective foods, which are fruits and vegetables, which protect us from the diseases. So nutrient requirement during adolescence. Energy and protein requirement is there. Energy is required for appropriate growth and development, and it prevents delayed increase in height and weight. So these are the RDAs for boys and girls, in which I have shown the energy and the protein requirement of an adolescent. Now, what are the sources? Energy sources are complex carbs and simple carbs. And proteins are like meat and fish, cheese, eggs, beans, bread, hummus, nuts, and seeds. They are the protein-rich foods. Now, fats. See, intake of fats always depend upon the calories that an adolescent is taking. 30 to 35% of fat we take from the total calories, and less than 10% of fat should be from saturated fat, because saturated fat is more harmful as the age is increasing. So RDAs says that between 13 to 15 years, boys should take 45 grams of fat and girls should take 40 grams of fat. In 16 to 17 years, boys should take 50 grams of fat and girls should take 35 grams of fat. And because increased consumption of fat can lead to cardiovascular diseases also and obesity. Now we come to micronutrients. Micronutrients are important equally as the macronutrients are important. And in junk foods, in normal food, we are missing the micronutrients, which has to be focused in every adolescent diet. First micronutrient which I have taken is vitamin A. The RDA for both girls and boys is retinol 600 micrograms, beta carotene 4800 micrograms. Vitamin A is important for normal vision, immune system, reproduction, and it also helps in normal functioning of heart, lungs, and kidneys. Next is vitamin E. It has an antioxidant property. RDA says that it should be present in the amount of 7.5 to 10 grams, like pomegranate seeds, sunflower seeds, nuts, kiwi, avocado, mango. These are the natural sources of vitamin E. Vitamin K helps in blood clotting process. The sources of blood clotting vitamin K are cabbage, cauliflower, tomato, spinach, green leafy vegetables, egg yolk, and meat. Now I come to vitamin B. Vitamin B includes a wide range of vitamins like thiamine, riboflavin, niacin, vitamin B6, and vitamin B12. And the functions of vitamin B are energy metabolism, amino acid metabolism, synthesis of tissues like RNA and DNA. And now what are the sources? The sources of vitamin B are whole grains, meat, milk, egg, legumes, sunflower seeds, nuts, leafy vegetables, and avocado. Vitamin C is an antioxidant. It helps in iron absorption. So citrus fruits, strawberries, bell peppers, papaya, leafy vegetables, kiwi, broccoli, guava, amla, tomatoes, they are the sources of vitamin C. Now we come to calcium and vitamin D. Calcium supports bones and teeth structure, and vitamin D improves calcium absorption and bone growth. The calcium sources are yogurt, sardines, milk, green leafy vegetables, and the vitamin D is sunlight is important, salmon, eggs, tuna, and fortified cereals. Iron helps in transporting oxygen in bloodstream, hemoglobin synthesis in girls to support iron loss with the onset of menstruation. Iron needs are the highest in adolescent growth spurt in males for muscle development and for female after menarche. Inadequate intake may lead to iron deficiency like anemia, especially in females. These are the iron-rich foods like beef, liver, egg yolk, potatoes with skin, broccoli, dried beans, leafy vegetables, iron-fortified cereals. These are the iron-rich foods. Next, calcium, which is required for skeletal growth, body size, and body mineral density. Insufficient intake may lead to osteoporosis in later stages of life. And RDA says 600 to 800 milligrams of calcium is required for adolescents. Zinc. It is very required for the vital growth and sexual maturation. Deficiency lowers the immunity, making adolescents more prone to infection. And these are the RDAs for zinc in boys and girls. Zinc-rich foods are pumpkin seeds, chickpeas, mushrooms, yogurt, spinach, and garlic. No, now the dietary guidelines says that we have to moderate the carbohydrate content in adolescent diet. We have to increase the calcium intake, protein intake, iron, and fruits and vegetables, which are the protective foods. Adolescent may avoid spicy and fried, smoking and drinking, and there should be a regular physical activity schedule in their daily life. It is very important. The nutritional concerns are like iron deficiency, anemia is there, vitamin A, calcium, iodine deficiency is there, generally found in adolescents. Obesity is one of the major public health issues which poses increased risk of diabetes, hyperlipidemia, overnutrition, and CAD. And PCOS is also a nutritional concern. Now I come to eating disorders. First is anorexia nervosa. Individual intentionally limits the intake of food because of strong drive for thinness or fear of gaining weight, which may lead to lack of energy, slow heart rate, irregular menses, dizziness, or fainting. Next is bulimia nervosa, in which individual eats large amount of foods and then purge, trying to get rid of extra calories. This may lead to life-threatening conditions, severe malnutrition, and depression. Diabeluminia, which is an eating disorder that affects only people with type 1 diabetes when someone reduces or stops taking their insulin to lose weight. And it is actually a real medical term. It is a media coined term. Anti-avoidant restrictive food intake disorder. It is an eating disorder in which food intake is restricted and there is a general resistance to eating, which results in significant nutritional deficiencies and extreme weight loss. Those with AFRID avoid many foods because they fear choking or vomiting, or they disturbed by qualities such as textures, smells, or colors of certain foods. Obsession with healthy eating is also a type of disordered eating. Yes, you read that right. Eating disorders are not always about binge eating, followed by purging or starving. Having unhealthy obsession with healthy eating, it is also an eating disorder. Rumination disorder, it is a disorder which involves a repeated regurgitation and rechewing of food after eating, whereby swallowed food is brought back up into the mouth voluntarily and is rechewed and re-swallowed or spat out. Rumination disorder can occur in infancy, childhood, adolescence, or in adulthood too. So can only a dietitian help to overcome disorders? No, dietitian can never help to treat, overcome disorders. It is recommended to seek help from a team of mental health professional, dietitian, and physician. Thank you so much.
Over to chairpersons for their expert comments.
Thank you so much. Thank you, Ms. Kanchan. It was a wonderful talk and very crisp and precise. It very well said that in adolescent we need to increase the level of calcium intake, protein intake, and iron and minerals, and decrease the carbohydrates. And besides the dietary thing, definitely it stands out like we need to increase the physical activity in adolescent age group.
Yes.
Has Dr. Anita Gupta joined? Dr. Anita, please.
I don't think, ma'am, she has joined. I don't think she has joined, ma'am.
Okay. Any other comments from any other expert? Thank you for introducing us to very new terms like dibulimia and avoidant restrictive food intake disorders. These are real clinical entities that are very, very relevant, especially to adolescent nutrition. So thanks for highlighting those points. Neeraj sir, you want to add anything?
May I say something, Dr. Anita?
Yeah, Amrita ma'am, please.
The best line was, obsession for healthy eating is also an eating disorder.
Yes, ma'am.
Very true.
Ma'am, this is very true, and this is very apt these days, because I've seen many boys especially, they are taking a lot of protein products, they are avoiding the normal food made in the house, and they are just busy bodybuilding. They are just they want to have good biceps and everything like that, and they are not eating properly the food we grew up normally eating, those kind of food. They don't want to take.
They go to gym and then they take protein
and the keto diet and
keto diet,
all sorts of things they are trying. And
even the girls, Dr. Amrita, they are doing the same thing.
Yes,
they are in their kitchen now. These junk foods have entered. They don't even know how we eat. Dal bhat bhajia is love so much, and they don't have any concept of it.
When junk is different, ma'am. Healthy eating kind of a thing. To have a good body, good health, nice, beautiful physique. I mean, they are obsessed with that.
And so, Amrita ma'am, it becomes more relevant to us gynecology, especially those who are fertility experts or they are dealing with infertility patients. These young adolescents, they grow into young adults and they carry on taking these protein and other, supplements which might contain anabolic steroids, which leads to, subfertility in these males.
Yes.
So, Dr. Neeraj sir, we are waiting for your comment.
Yeah, Dr. Anita, and one more thing is with the influence of social media. There is so much influence of social media on this adolescent population, and with this, they idealize the body and they want to be like that physique. So that's why the issue is there about the nutrition and health. So it's a very important. So next topic, I think we are covering that internet addiction, and social media is a very much influential in today's adolescent population.
Thank you. Over to MOC for the third session.
Thank you, ma'am. We start the third session on internet addiction. I call the chairpersons for the session, Dr. Latika Bhalla. Ma'am is Senior Consultant, Adolescent Pediatrics, Institute of Child Health, Sir Gangaram Hospital. She has major achievements of Diplomate of Child Board, Adolescent Pediatrics, Fellowship Endocrinology, working as a consultant adolescent pediatrician, taking care of children and adolescent health problems. She has honors like Delhi AHA President and past Secretary, Delhi AHA, Secretary, Adolescent Health Academy, to name a few. Welcome, ma'am. I also invite Dr. Shweta Mathur. Ma'am is she has special interest in gynae ultrasound, Secretary NOGS, past Treasurer NOGS, experienced orator, and speaks on women wellness of various MNCs, in clinical practice for past 20 years, and visiting consultant in major hospitals in Noida. Welcome, ma'am.
Thank you.
Dr. Neeraj Jadhav, Sir is Chairperson, Sexual Medicine Committee, FOXY 2020-23, Vice President, Rajkot Menopause Society 2020-22, West Zone Coordinator, FOXY Adolescent Committee, Joint Secretary, Rajkot OB-GYN Society, past Secretary of OB-GYN Rajkot Society, President of Rajkot OB-GYN Society. Welcome, sir.
Thank you. Thank you. Good evening to everyone.
I request Dr. Neeraj to please introduce the speaker.
It's my privilege to introduce our next speaker, Dr. Deepak Gupta. He is a child and adolescent psychiatrist, founder and director of the Center for the Child Adolescent Well-being, the CCAW. He is senior consultant at the Sir Ganga Hospital, President Appreciation Award. He has got many eminent medical awards. So I welcome you, Dr. Deepak Gupta, sir, for your talk on internet addiction, which is a very relevant topic in today's time. So over to you, Dr. Deepak, sir.
Yeah, good evening, everyone. Am I audible, ma'am?
Yes.
Yes, yes. Yeah.
Yes, sir.
So first of all, thank you very much to the society for giving me this opportunity. And as usual, thank you to Dr. Mala Srivastava for inviting me. 2 months back also, she invited me for one of the talks on this same topic. And it's again, I'm back here. It's always a very interesting topic and also a topic of the need of the hour. As we into the almost 23 months post-COVID things happened, we have seen a lot of cases of internet addiction, and we have seen that internet addiction being a big problem across all the strata and along the society. Let me start with a small case vignette. Very, very common presentation. A 16-year-old boy studying in the class 11th. Excessive video game playing for almost 8 to 12 hours per day. And on the weekends would increase to 10 to 14 hours. This is one of the examples, but I have cases where I have children and teenagers for 16 to 18 hours in a day also. So out of 24 hours, 16 to 18 hours in a day. Constant need to be playing and finishing levels, gets angry when loses online, gets aggressive when prevented or stopped, in his room the whole day. So that's one of the major concerns of the parent. The child does not come out of the room. Always in the room playing, you can't disturb. If you go and disturb and ask him to come out for lunch or dinner, they get irritated, they bang the door, they shout at you, they become abusive, aggressive, defiant. He stopped attending school and playing sports. He was good in studies till 10th standard, declined in academic over the past 1 year. Keeps awake whole nights and sleeps in the day, does not believe he has a problem. Family discord is present, and is blaming parents and fighting with them. When I saw this case, a live case, which I saw 3 years back, the mother was so frantic and she was so disturbed that please save my child, who was a topper till 10th class. Now I don't know what has happened to him. That is where she came to me. And then we worked for 2 years, 11th and 12th class, we worked with her for 2 years. And finally, after working for 2 years on the internet addiction, the student passed with more than 95% marks finally. So, though I'm presenting this case, I'm also saying that a lot of help and interventions can be done. It's not that I know when the problem happens, we feel helpless. We feel that nothing can be done. As parents comes to us, as professionals, they feel so miserable. But yes, a lot of things can be done with them. So why is internet addiction important? Why? Why is this emerging field important? Because one, it is felt that internet addiction is on the rise. And in the COVID, in the last 23 months, it has increased drastically. Now, one more thing is that internet addiction disorder may not be a single disorder. It may be part of a spectrum of multiple disorders together. Internet addiction, ADHD, depression, anxiety, a lot of things. It could be a combination. It's not that only internet addiction. It could be just a manifestation. But underlying, there could be something else which we need to address, which I'll tell you gradually as I do my presentation. So it's an interface between technology and mental health. One aspect is the technology and one aspect is the mental health. And in today's world, we cannot say no to technology. See, today we are almost 150 professionals are sitting together because of technology. Across the country, across the different strata, across the different thing, we all are sitting because of technology. Why? Because technology is quite helpful. But when this technology overrules you, then it becomes an addiction. That is called a behavior addiction. Now, but as it's a very, very early stage, they are in the nascent stages, and a lot of experience is required still in this field. Treatment has to be a combination of medical and non-medical intervention. It's not that we have a magic pill. You give a pill, the child comes of it. No. So it has to be a combination of a lot of non-medical, a lot of psychological interventions, a lot of counseling of the family, of the teenager, and then if required, medication only in certain aspects are required. And sometimes, as I was talking about, the social media addiction, which Dr. Neeraj was talking about social media, it could be an underlying psychopathology. A lot of times, the adolescent is angry with their own parents. A lot of times, they have been a victim of bullying. And that all is leading to social media addiction. A lot of times, they have body image issues, which the previous speakers were talking about, like body image issues. And because of body image issues, they get into addictions. We'll talk about all these issues. And it is seen in both genders. It is not that it is only limited to females, girls. No, it can be in girls and boys both together. It can be even in small children also. It's not that it is common in teenagers only. It can be even seen in pre-adolescent children also, 8 years old, 10 years old, and even in adults also. Whenever I do my presentation on a humanist note, lot of adult population, a lot of adult professionals tell to me, we know so many adults, and there may be some of them even in the audience, some of them says on a laughing mode, which may be having internet addiction. So that's what the internet addiction has gone to that rate, that's increasing across all the age groups. Now, this is a very interesting slide by American Academy of Pediatrics, and also Indian Academy of Pediatrics also support this slide, that 0 to 2 years, the ideal screen time is 0. Face-to-face human interaction and playtime is a must. 2 to 5 years, maximum to maximum 1 hour. But the content should be carefully monitored by parents. And 6 to 18 years, maximum of 2 hours per day. We all, after hearing this, we all may laugh it out. The 2 hours per day, it's so less for a teenager, today's teenager. But that's what is required. And we have to also differentiate between academic and non-academic, because a lot of things are being done online today. The schools are going online, the college is going online. So one is academic and one is non-academic. The non-academic is 2 hours per day for leisure use on all devices like phones, tablets, computer, gaming consoles, iPad, etc. Productive use of technology for homework is separate. That's important. So a lot of time when parents come to me, they get confused. But then when I delineate, when I tell them clearly, then they are able to identify academic and non-academic. That's what. Now, what is internet addiction? Internet addiction is not yet a formal clinical diagnosis. In 2022, January, which has gone, WHO was supposed to come out with a classification, a new classification, and internet addiction was supposed to be officially declared as a disorder. But due to COVID, everything has got postponed. So right now, it's not a formal diagnosis, but yes, very soon, I'm sure in this coming months, it will become a formal clinical diagnosis, IAD. Now, the question is, when is it an addiction? One of the very pioneer person in USA, Dr. Kimberly Young, who has done a lot of work in internet addiction, she has outlined certain criteria. And one of the 6 criteria is preoccupation. Once you're preoccupied with internet use, which leads to constant engagement in the activity, you're constantly occupied. Aapke mind to wohi chalta rehta baar baar. How can you use it? You may be sitting in front of your books, but then as you want to, but you're just only occupied with the games, with technology, that's all. You want to play the game, PUBG. That's a game constantly coming in your mind. And gradually it increases every day. You got urge to increase every day. It may be 2 hours, then 3 hours, then 4 hours, then 5 hours, then 6 hours, then 7 hours. Recently, I saw a girl, a 14-year-old girl, to the point she came to a point that if you won't give me the phone to play the game, I will kill you. I will kill you. To the point the parents had to call the police to settle down her 14-year-old young girl. So the urge is there. They neglect other important responsibility and commitment. They use internet to forget about personal problems. A girl who has been going for dance, for music classes, or doing other classes, household chores, baking, cooking, she stops everything, or he stops, and gradually the internet becomes a life. The withdrawal symptoms. When you try to withdraw them, they become trouble, they become restless, they become aggressive if prohibited from using internet, and negative impact on relationship, work productivity, general mental, physical, healthy, and daily functioning. And the major thing which really disturbs the parents is 2 things. One, they find that the child becomes aggressive, and second, their academic decline. A child who was getting 90% or 85% or 80%, the marks come down to 30-40%. So these 2 parameters, the academic decline and the behavior aggression. So preoccupation, urge, neglect, forget about personal problems, withdrawal symptom, and negative impact on the various aspects of this. So this is what is internet addiction. Now, internet addiction contains different aspects. It could be social networking, like too much of YouTube, too much of like just or chatting, or online shopping, or compulsive online gambling, excessive blogging, compulsive watching of internet videos and pornography, and playing online games. So it could be multiple parts. So it's not only using, it could be Facebook, it could be YouTube. I have some of the teenagers who are too much on only YouTubes. It's 7 to 8 hours of YouTube every day, watching videos, and uploading their own videos. And some of them only on Facebooks, some of them only on Insta, only on the Insta. And Insta expanded so much, of Instagram has expanded so much now. They can chat, they can do shopping, they can upload the videos, so much. That's what. And this online shopping and blogging and gambling, it is slightly less in teenagers. Blogging can be there, but this gambling and shopping is less in teenagers. Mostly it is 20 plus or 25 plus. That is where the shopping and gambling comes more. In teenagers, it is more of this social networking and playing online games, and sometimes blogging, and sometimes pornography stuff. Now, this is very important. We have to differentiate between what is users and what is addiction. Some of them can be excessive internet users, overly engaged in internet, but they stay in control. That means they may be using 3 to 4 hours in a day, but they appreciate other activities. They lead multi-dimensional life, multitasking, and their academic decline does not happen. They may sleep at 2 o'clock, but at the end of the day, they're able to complete their other chores also. There are no school complaints. In the end, parents are a little disturbed, but they are in control. They don't stop other activities. Now, on the other end, internet addiction, it is compulsive, uncontrollable, unfavorable consequences. They stop other aspects. And that interrupts internet usage is disfavored despite negative consequences. So the academic decline goes, academic decline is there, relation conflict is there, insomnia is there. And despite that, they are not able to stop it. So they know something is happening wrong, but they said, no, we need it. We need to play. Kya galat hai? Hum karte hain to. Hame maza aata hai. Kya dikkat hai? And sometimes if you probe them further, they say we can't stop it. We enjoy it. Padhai to baad mein bhi ho jayegi. So these are some of the addictive phenomena. Some people have even compared internet addiction on a spectrum of like substance abuse, like alcohol, smoke, cocaine, weed. So that's why even internet addiction has come into a addictive, the whole spectrum of addiction disorder. It's like a behavioral addiction. The one of the major problem with internet addiction is that internet is easily available inside the house. The other substances like cocaine, like weed, like smoke, you have to get it out from the house. And now very soon we will be exposed to 5G. As we know, on the 1st of February, the budget was in that the Honorable Finance Minister said this year the 5G will be rolled out. So imagine with rolling of the 5G, the speed and the network connection will be increased so much. So we will see more and more cases of internet addiction. That's a speculation. Now, how intense is the problem? 1/3 of the global population uses social media. 95% of all users are on the go. Every minute, around 5 lakh comments are posted, around 3 lakh statuses are updated every minute. Around 1.3 lakh photos are uploaded, while the average user spends approximately 20 minutes daily on the site. This is a big figure that is of 2017. I'm sure the new figures will sell more and more. There's one of the very prominent clinic which is run by a Shut clinic in Nimans, Bangalore. They're one of the pioneer people working in internet addiction. And they found that 73% of adolescents, almost 2/3, who uses tech devices report dysfunctionality in one or more daily activities. That means around 73% are getting affected due to internet usage, which is a big number. These are some of the articles, how the addictions has impacted people, how the UNICEF has warned the people about digital world for children and teenagers. Now, what has COVID has done? Now, in COVID, what happened? There was lockdown, as we all know. So what happened? Because the teenagers were get confined to the 4 walls, children, there was an increase in loneliness and boredom. So internet usage became more and more. Along with that, the teenagers also started feeling inadequacy, FOMO, fear of missing out, and dissatisfaction. This led to the negative effect on the mood. The stress, there was a worsening of the stress, anxiety, and depression, and more use of internet, which led to internet addiction. So it became a vicious cycle. Loneliness leading to the more and more use of internet, inadequacy, negative effect, stress, anxiety, depression, and more. So it's perpetuating the vicious cycle of unhealthy internet usage. What are the risk factors? Why these risk factors are important? If we are able to identify these risk factors, we can work on them. We can work on these risk factors to help the teenagers. So college students are especially vulnerable. Availability of time. That is why we need to keep our teenagers busy. That is why we need to keep our adolescents busy. Khali dimag shaitan ka ghar, sahi kahavat hai. We need to involve them. Very important. We need to involve them into various activities. Unlimited access to the internet. Limited or no parental supervision. That's again one of the things. Permanently logged in status. Always this logged in status is there. Using the internet for chatting, pornography. Social anxiety, poor social skills. Depression, low self-esteem. ADHD. So some of these are the risk factors for internet addiction. And COVID-19 lockdown, limited outdoor activity and social participation. So these are something which we need to look into it. Now, if we need to explain the internet addiction, how can we explain it? So it is a combination of not only one particular factor, multiple factors are there. Neurobiological factors, socio-cultural factors, personality and behavioral factors. Let's see. Coming to neurobiological factors, the dopamine is implicated. So whenever we talk about addiction, we talk about dopamine. What they say, when we tend to use internet and when we tend to use anything which helps in gratification, there's a high dopamine release. So when we go to Facebook or the Insta or somebody, and when we get a good score or more liking, we get a kick and we get a dopamine rush. So we tend to do more and more. Or there's a synaptic pruning, which ensures optimal connectivity in brain. So, or there is a delayed maturation of prefrontal and frontal cortex during adolescence. So what happens is that they believe if there is a delayed maturation, So they believe in all or none phenomena. So those areas are not adequately developed. And also one more thing which has been seen, this increased activation of the limbic system. When there is increased activation of the limbic system, there's a high likelihood of risk-taking behaviors, less control of emotional reactivity. So why I'm telling all these factors is that there is a biological basis also. It is not that it is only psychological. It is not only because they're inside the four walls. There is something which is biological also in addiction. So we need to have a full biopsychosocial model to address it. Coming to the socio-cultural factor, the family dynamics. If they're observing their parents or using too much of internet, the parents are using too much for 8 hours, 9 hours, even while having dinner, they're constantly on the phone. Status and fame from the other peer groups, competition and social comparison. Again, that adds to the internet excessive use. Coming to the personality and behavioral factors, like entertainment, popularity, or in the past, if they've used internet and which has led to the avoidance of negative consequences, it is more likely to occur again. Negative self-concept, like I'm not good enough. And when they feel I'm not good enough, and when they go to internet, that gives them a kick. So all these factors, including FOMO and nomophobia, that leads to the more and more use of internet. So you see, there's so many factors which can cause internet addiction. It is not only lack of parental supervision. It is not only too much of internet. So multiple factors are there when we are assessing for internet addiction. So what are the various effects? In a nutshell, the productivity goes down, academic underachievement, compromised family and social life, time alteration. They tend to escape from the real life. They go into virtual life. Depression, social anxiety, self-esteem goes down. Phantom phone vibrations, back or wrist pain, a lot of physical issues and sleep problems. So as a professionals, what is important for us? If there is compulsive and uncontrollable urge to use, so any parents comes and tell, my teenager is having uncontrollable urge to use, she can't control, our time is increasing day to day. That means we as professionals have to get alert. Something is wrong. Second, if it is interrupting day-to-day functioning and other interests, we have to get alert. Third, if there's unfavorable consequences like poor school performance, insomnia, the child not sleeping till 4 o'clock, 5 o'clock, there's alert. And the fourth, if they have withdrawal symptoms like restlessness, anger, when not using internet, they need help. So these are the 4 factors which as a professional we have to be careful. One of the very important questions which parents ask me, which is important for us professionals to tell to the parents, what can we do to prevent it? The first important thing is establish a tech-free time and zones at home. That means there's a particular time when there's no technology. It could be a Sunday, it could be a Sunday lunch, it could be evening dinner, it could be a family time. That time no mobiles. So कोई भी mobile use नहीं करेगा, सब अपने mobile side में रख देंगे. That is important. ये आप कर सकते हो, ये मैंने अपनी पर्सनल लाइफ में करके देखा हुआ है. I tell you, it works. It's almost like a partial digital detox. Second, be a role model. Today, teenager doesn't have a role model. The buck starts with you as a parent, the buck ends with you. You want to teach a teenager, be a role model for him. और उसको जताओ मत. देखो मैं करती हूँ ना ऐसे, तुम भी ऐसे करो. जताओ मत. वो आपको देखेगा, आपको परखेगा, फिर वो फॉलो करेगा. जताने से वो और आपसे दूर हो जाएगा. तो उसको ताना मत मारो, उसको ब्लेम मत करो, ऐसे नहीं करते, नहीं. Role model, healthy habit. Make screen time a privilege. Establish the clear rules about electronics. No electron during meal time, 1 hour before bedtime. And you also follow that. Encourage physical activity and real life social interaction. As the COVID is now going down gradually, again we can increase the physical activities. अगर आपका छत है तो उसका फायदा उठाइए. अगर if you have something where you can do it, you do it. If you have a garage, you can play with your child. Definitely play with your child. Create a screen-free days and vacations. When you go for a 2-day vacation or a 1 day, we all are busy professionals. So we can always, in our own personal life or to our parents, if they're going for 2 days, 3 days, make sure they try to make a rule that we won't use screen for those 2 days or 3 days. Turn off instant pop-off or badge notification so that it doesn't keep on popping off again and again. When it pops up, you tend to keep on looking again and again. Limit the social media accounts. We have so many accounts today. We get lost. As a parent, we should be part of their virtual world, like Facebook, like Insta, whatever. We should be part of that. And also talk to your child about digital dependence. Talk to them openly. Kya nuksan hai, kya fayde hain? What all can we do? How they can harm physically, psychologically. So these are some of the prevention which can be done at home. So basically, in a nutshell, ABC: awareness about cyber literacy, be a role model, and seek communication. In the end, if still it is a problem, please refer them to a team who works with internet addiction. What does a team do? If their team works on these are some of the different platforms where we work as a team. So we have a full team at CCW and also at Ganga Hospital. So what we do, we work on the behavior. We specific how to modify their behaviors. Cognitive restructuring by work on the thought process. What are the contributing factors? By supporting the school and the parent counseling, which is very, very important. And if really required, we give them medication. If really required. Let me share, in the last point, let me share with you my examples. In my so many years of working, especially in the last 7 to 8 years, working on the area of internet addiction, I've been able to divide into 5 areas. This is not on the Google. Rest everything you may find it on the Google. So I've been able to divide the population into 5 zones. The first zone is one, the teenagers who are very impulsive, who have underlying ADHD. Because they're so impulsive, that's why they keep on using internet. You work on the ADHD, they improve. Second is angry. They're angry with the parents, they're angry with the social environment. That's why they keep on using. So you work with the counseling on their anger and aggression, they settle down. Third, who are depressed, low self-esteem. You work on the depression, low self-esteem, confidence building, counseling, medication if required. The depression improves, the addiction also goes away. Addiction is just a manifestation. Fourth, who are anxious, social phobia. Because of anxiety, they don't want to face the world. They're constantly on the virtual world. You work on the anxiety, again, build their confidence, work in the social anxiety, they improve. And the fifth one is the real novelty seekers, who says, we just want to use it because we want to have fun. That is the most difficult population. They are the true internet addiction one. The rest of them are because of the multiple issues. So in the end, the take-home points, many adolescents now live much of their life in an online social context. And how this will influence their emotional and social development remains a vast experiment in progress. Family and school should have an integrated approach towards the prevention and support for social media addiction. The important point is, don't disconnect from social media. Instead, create healthy usage habits of social media. I want to end up with this cartoon where a blind man is helping a young man who is excessively busy in their technology to help him to cross the road, and who has a pothole in front. Thank you very much.
Very nice, sir. Your last slide has summarized the presentation in one slide. Over to chairpersons. Yeah, over to chairpersons.
Yeah, I think Dr. Deepa Gupta has covered everything in one, maybe last 20-25 minutes. He has there has been so much of experience he has in dealing with the ADHD and other patients. So that probably has been dealt all. So as an adolescent pediatrician, all of us, even the gynecologist, obstetrician, we all deal with adolescents. So we need to know what is the psychosocial behavioral history of the child. So one history which can be taken once we are doing so much with the children, what is called as a HEADS assessment. So this is an acronymic for the HEADS assessment is home and environment and education and employment activities like a media usage. We can ask them, what are they on? How much are they using? Whom are they talking? Who is there on other side of it? So there may be drugs also, which may be in form of a tobacco and alcohol. Or then, of course, we need to talk to them about their sexuality also. And the suicide ideation is very important. Every fourth child, India is the fourth highest country where the suicide ideation is so much common. And of course, the spirituality has been added to the heads recently, and that is why it is so much important. So already the anticipatory guidance has been dealt, but as adolescent pediatrician, or even you can say in form of, we can say like even the gynecologist, we should tell each child what is his boundaries, like how much time are they spending on that, how much is the balance between the family life and the home life. And then the communication has to be very true. It has to be an excellent communication. And all of us, because once I deal with the school health children also, we have dealt a lot of on the Kimble Young I8 scoring system, where we have seen there are a lot of children who are into it, and there are almost 60 to 70% children, in whether they are in Delhi or whether they are in Haryana or Uttarakhand, everywhere, whether they are using smartphones, whether they are using my broadband, everyone is being affected by the same. So that is why it is very important for every parent to know, to be web wise, and all of us, we should know and communicate with our children. So other thing which is very important for every person, there should be 5 P's for the digital printing. We must tell all the children, whatever we write once, it will remain forever. So in the profile, they should be very careful, not disclose their names. Then they should protect their passwords. The privacy has to be maintained. And then the permission has to be there. Whatever they're posting, whether it is a good kind of a content or whether it is a bad kind of a content, that also has to be seen. And then the information has to be positive. So we must tell every adolescent, think is whether whatever you are posting, whether it is a true, whether it is a hurtful, whether it is a illegal, or whether it is necessary, or whether it is kind. So every child has to be explained about the anticipatory guidance. All the physician, adolescent pediatrician, even the obs gynae person, and of course the psychologist, psychiatrist will take a psychosocial behavior history, because everything is all connected. So even if the child is coming to with anemia, or maybe if you ask a history of anemia, or if the child is not able to sleep well, or if the child is feeling there is a lower decline in the academic performance, all these things will come together. There may be evidence of anemia, there may be evidence of obesity also. Obesity in form of they are not eating right. They are eating that kind of a food which probably was already dealt in the second lecture. So they were kind of a food which they are eating, or sometimes they are eating too less, or they are eating too much to have a Ashwarya kind of a syndrome, or maybe a Hrithik Roshan kind of a syndrome, to improve their body images. So very, very important for every person to be aware of all this. Thank you so much. And thank you, Dr. Deepak Gupta, for a very lucid talk. And it was an eye-opener. And this time it was probably even much better than what it was dealt the last 2 months ago. Thank you so much. Thank you, Dr. Mala and Dr. Anita, for giving me this an opportunity. Over to other chairpersons.
Thank you, Dr.
Yes, yes, go ahead.
Thank you, Dr. Deepak. Now we know that starting from the ABC to Z of internet addiction. Thank you so much. And you have really correctly highlighted that internet addiction may be a manifestation of the unfulfilled aspiration due to the bullying or body image issues or a family discord. There's the paucity of any other good quality time spending with the family and all. And video gaming and YouTubes, they provide instant gratification, and they provide rewards and challenges. So it gives a sense of achievement to the kids. So I think it's time, as you have said, that we have to talk about digital diet, when to start, how much to give, and it should be digital nutrition. It should not become digital poison.
Yes.
So that's really very good. And thank you, Dr. Latika, to guide us how to talk to our teens
that we should remember about the 6 Ps. It was a really very interesting topic. Thank you, Dr. Deepak and Dr. Latika, and having me here. Thank you so much.
Neeraj sir, you want to add anything?
Yes, it was a very wonderful presentation, Dr. Deepak. Technology, we all know, is a double-edged sword. It's a much needed in recent time. Without technology, we can't do anything. But we have to keep in mind when not to cross that border where it become addiction. And we all also observe in our OPD also that whenever patient come with a small child is not disturbing everyone, parent will give them mobile. They will sit silently and watch YouTube and whatever they want to. So it beginning from the early age. So we have to keep that in mind. And one more thing is this pornography and sexual applicable material. With so much material available easily to our adolescent, it inhibits their normal sexual development. So we have to keep that also in mind. That we have to think about that. And it's very wonderful lecture, Dr. Deepak. It's a really eye-opener for every parents. We all know that it's easy to say, but difficult to manage this internet addiction. Not for everyone adolescent. For us also, it's very difficult to control this internet addiction. So they as a child, they follow us. So we have to be more cautious about the yes. We have to be role model.
So thank you, chairpersons and Dr. Deepak. Over to Dr. Ankita for next session.
Thank you, Dr. Anita, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you, chairpersons and speakers, for a very enlightening session. Everybody really benefited from it. Now we start the next session on complexity of adolescent psychology. I request the chairpersons to come on stage. Dr. Aradhana Singh, President, Noida Obs and Gynae Society, Senior Consultant and Labs Surgeon, Fortis Hospital, Noida, Organizing Secretary, North Zone, Yuva Foxy 2019, Past Secretary, NOGS, Chairperson, Sexual and Reproductive Health Committee, recipient of Young Talent Contribution to NOGS in 2016. Welcome, ma'am. Dr. Amrita Jaipuriyar, ma'am is Consultant Gynecologist and Obstetrician, Jaipuriyar Medical and Research Center and Garg Hospital, Gorakhpur. She's President, Gorakhpur Obs and Gynae Society 2021 to 23, Secretary, Gorakhpur Menopause Society, Secretary, ISOPAP Gorakhpur Chapter. She is editor of all souvenirs of above conferences like Workshop, Maternal Mortality, and CIFOG 2019. She's organized Hysteroscopy Workshop in 2019, Gynae Endoscopic Workshop at Gorakhpur Garg Hospital.
Thank you, Ankita. Thank you, Ankita. Move on. I'm here. Thank you.
Welcome, ma'am. Dr. Subuhi Rizvi, ma'am is Director, Mother's Clinic and Ultrasound Center, Fetal Medicine Foundation Certified, UK, Advances in Fetal Medicine Course, UK, Secretary, Gurgaon Obs and Gynae Society, and she has started Heal India program for adolescents and their parents. Welcome, ma'am.
Thank you.
I request the chairpersons to please introduce the speaker.
Yeah. So thank you, Ankita. May I have the CV of Dr. Soumya? First of all, thank you, Dr. Mala and Dr. Anita, ma'am, for giving me this opportunity in this wonderful CME. I'm really enjoying, and the last lecture was really mesmerizing and was really an eye-opener for all of us. So Dr. Soumya Tandon, may I have her CV, please? She's going to speak on a very, very important topic of complexities of adolescent psychology. We just had a lecture, and let's see what Dr. Soumya has to say. Dr. Soumya is a associate, she's a DM child and adolescent psychiatrist, and she's associate consultant psychiatry at Sir Gangaram Hospital, and her areas of interest is child and adolescent psychiatry. Welcome, Dr. Soumya.
Hello, good evening. Thank you for having me here. And I'll be speaking about the complexity of adolescent psychology. So the period of adolescence, as we all know that this is a transition phase between childhood and adulthood. So there's growth in different domains, all of which are interconnected. There's intellectual growth, emotional growth, physical growth that I'll be discussing in the later slides. So ultimately, there's attainment of one's own sexual abilities, developing a social niche, and a sense of autonomy. So this is the beginning of a phase where a person experiences most cherishing memories as well as most embarrassing moments. So that is what is adolescence. Now here is the conceptual framework about how do the individual capacities grow as a part of the developmental process. So here I'll be discussing about them. So there are biological, cognitive abilities, emotional capabilities, developing social skills, and moral values. So they occur simultaneously. So there's simultaneous development of these mental events that take place in these different domains. And all of these are related to one another, and they also influence one another. And at any moment, an individual may be more mature in one domain than in another. And in each phase, there are tasks and responsibilities that need to be handled to be able to successfully progress over onto the another phase. The biological changes during adolescence, the pubertal changes have been discussed in quite detail, so I'll not be covering this. I'll proceed further. Coming to the brain development. Now, this is a very important aspect because even when we talk about psychology or psychiatry, it is not just the behavior or the thinking. Everything is determined by our neural structures. The brain is the primary organ that is handling everything. So this is a very important topic. So here the first is about brain myelination. So brain myelination starts right from the infancy, and it proceeds through the period of childhood and adolescence. Now, along with brain myelination, there's another process that accompanies is synaptic pruning. Now, what happens is that in brain we have millions of neurons, and we are born with much more than what is actually required. All the neurons are connected via these connections, which are called as synapses. Now, over the process of development, the neural pathways and the networks that are constantly stimulated and are in use remain. That the other that are not used and are not relevant, they are pruned away. So the process is a continuous one, and the patterns and timing of these changes, they affect our cognitive functioning. I will be discussing what we mean by cognitive functioning later. So there have been plenty of studies, plenty of good studies, and both structural and functional MRIs, they have reported that the patterns for both myelination as well as synaptic pruning, the pattern starts from posterior to anterior part of the brain, and then from inferior to superior part of the brain. So that's how the pattern is followed. Now, I would like to mention this study that's a very important and a seminal work which was done by Godke et al. In 2004, it was published. So here what they did, that the researchers, now this is a follow-up study of MRI of, they took 30 healthy children, and they were followed up from the age of 4 to 21 years so as to see how does the brain progress, the maturation progress. So the cortical maturation was seen. Now, if my cursor is visible, the top portion above the arrow, this represents the right lateral aspect of the brain, and the below part, it is giving a superior or a top view of the cerebral hemispheres. Now, this is what is the color scale, which indicates the maturation. Here, this is the most maturation. This is the most maturation area, this is the 0. So here we see that as with the progressing of age, the cerebral cortex matures. So from 4 to 21 years of age, the cortices have been maturing. So what is the difference between childhood versus adolescent versus the adult brain? Because that is how we'll be able to actually relate the behaviors. So I would be discussing about two main areas here. One is the subcortical area, the other is the prefrontal area. The prefrontal cortex is a part of the frontal cortex. The subcortical structures are the structures which are beneath the cerebral cortex. They will include the thalamus, the basal ganglia, the limbic structures. So what happens is in children, both the systems are in a state of development. So both are immature. In adolescence, what happens is that the subcortical the system is mature, but the prefrontal cortex is still developing. Now, it is the prefrontal cortex that that puts the brakes on the brain if there are some impulses. So that is the area, the prefrontal cortex, that will say, no, you have to wait here. So here, this is the special part of adolescence, that the prefrontal cortex is still developing, whereas in adults, both the systems are fully mature. Now, this gives result to risk-taking behavior in adolescents. Now, they will do acts, their behavior will be such that they will do without thinking about the consequences. So that gives rise to impulsivity. Now, this was another triadic model that was given by Ernst in 2006, wherein there have been 3 domains that have been mentioned. One is, and this is applicable with every individual right from birth until the further period. One is approach. Approach is how do we approach a novel situation? How do we approach a person, an event? So that is approach system, and that is based on the model of reward system. The second is avoidance. Avoidance is similarly that if there's a new person, a new place, a new situation, so to be able to not approaching that, withholding oneself back, so that is the avoidance behavior. So ultimately what is required is a balance, is a regulation, and that regulation is very much important, and that is controlled by the prefrontal cortex. Now, as we discussed in the previous slide, that the prefrontal cortex is not mature in adolescence, and hence the risk-taking behavior during adolescence, what is seen is increased approach, and there's a weaker influence of the regulatory system. So that puts the adolescent at risk of impulsive behaviors. I come now to the cognitive development. So cognitive development, cognition means how we think, the thinking process, how it progresses, the memory, everything. So here, there was a very important person by the name of Jean Piaget who devised the cognitive theory of development. And that cognitive theory of development starts right from when the child is born, and it's divided into phases. And so I'll be talking about the adolescent phase, what goes on in the mind and how the thinking is developed. So there are 2 very important theories that were formulated. The first is the information processing theory. The second is the concept of metacognition. Coming to the information processing theory. So here it describes about how we store information and how the memory is formed. So we have the sense organs, and whatever we get through the sense organs, that gets registered for a few seconds in the sensory memory. Now it is the process of attention. If we pay attention to any particular kind of sensory stimuli, that is going to stay there in the neural circuits for some time, and maybe a few hours. So that gives rise to short-term memory. Now, in the short-term memory, what happens is it is very, now it depends whether the short-term memory is converted how to the long-term memory. So it is by the process of encoding. Now, the core fundamental of converting short-term memory to long-term memory is repetition. The more the repetition, the more the encoding and the more the memories, integrates. The second is connecting it to previously learned material. Suppose I learned something new today in my subject. If I relate it to what I learned, it maybe the last lesson. So the more connections I make, the more probable I am to retain what I've learned today in the long term. So this is the information processing theory. The second is the concept of metacognition. Now, metacognition is also a very important concept. So it is the awareness or analysis of one's own learning or thinking process. If I'm thinking something, I have a thought, that is cognition. But if I analyze that thought, if I analyze my own thinking, if I analyze my own patterns, that is a metacognition. So that's a high level reasoning, and this metacognition starts to arise during the period of adolescence, and it progresses as the individual advances in age. So what are the key factors that are involved in metacognition? Planning, how to approach a task, how to monitor things, how to monitor oneself, how to evaluate progress if one has to complete a task. And so there's something that we call as executive control. So it's a part of the executive control. So executive control is a very core process of brain functioning that includes the working memory, attention, being flexible mentally, inhibition of impulses, organizing everything. So these are all complex cognitive abilities of the brain. This is a case vignette. So there was a 14-year-old girl with falling grades in school, and she was becoming distressed as she would spend time doing the homework and studying, but that would not seem to work. Her parents were extremely worried, and there would occur frequent conflicts between them, and they would shout at her for not completing her work and tell her that she would spend most of her time messaging her friends. The patient would admit that she would have, spent time on the phone and talk to her friends, but she would say that this was much less than as compared to all her friends. And then she was brought to the OPD. Now, IQ was normal. There was no history and examination, no history suggestive of any learning disorder. So here, the metacognitive strategies were discussed for studying. The steps were clearly written and improvement in grades were observed. Now, what could be the strategies I will be discussing about this? The first is to set a goal. And for that, the very important thing is to assess motivation. Until and unless a person has a motivation for a given task, it is not possible to proceed forward. Motivation is the core for learning process, for development. So that motivation needs to be assessed. If not, the motivation needs to be built up, and it is not difficult to actually use strategies to build up motivation. And after motivation, the child or the adolescent, like for example, says, I would like to do this paper well if there are exams coming. So the adolescent says, I would like to do this paper well. Now here we don't focus about how much, like what grade would you want? Would you want A, only A? That would create pressure, or only more than 90%. So that should not be the strategy. It's that, okay, the effort lies in my hand. I'll try to do it to the best of my ability. The second is to activate prior knowledge. This was, as I discussed about the information processing system, how to actually convert the short term into long term memory. So whatever the new content of learning is, it is very important to connect it with the prior learning. So the connections increase, and that's the understanding increases. So it's important to understand what I really know, and from the new material, how can I connect with that, and what inference can I make? So that gives a lot of practical meaning to it. And then to make a learning plan. So here, what happens is the core is organization. Now, how to do? Suppose I find physics difficult. I find mathematics difficult. So it's important to prioritize. What is the difficulty? Where lies the difficulty? So I have to have an understanding of my performance. So I estimate the time. Okay, so the boards are approaching next month, and I have a month in hand, and maths and physics are difficult. So I make a schedule wherein I will do maths and physics first, and then I also give time for revising whatever the difficult topic is, so that I'm able to retain well before the exam. So prioritization, estimate the time needed, making a schedule. This is all about organizing your time. And then managing our own self, managing our the adolescent, monitoring the progress, and choosing the best learning strategy. Now, everyone has got a different learning strategy. For some people, they pick up the visual parts. The visual attention is better. For some people, auditory attention is better. And while studying, some students will stick some sticky notes and make short points that will be revised only briefly at the time, and some will use highlighters. So everyone has got a different uh, learning strategy. So it's very important to choose the best strategy, because that's going to help. And then, for example, having some kind of a mock test and understanding what we have comprehended for whatever we have worked for. So these are some of the self-management strategies. So the strategies, I will again say, because this is important: setting a goal, activating prior knowledge, making a learning plan, and self-management. These strategies should be used. Coming to the next domain, that is the emotional development. Now, emotional development here, it's in continuation of the temperamental characteristics. Now, what is temperament? Like, temperament is the word, the uh, the set of capabilities, the how a child responds to the environmental stimuli. A child is born with temperament, and when the child grows, has environmental experiences, and that's how the temperament and the experience will crystallize into the personality. So it's a lengthy assessment. It's got 9 domains, one of which is mood. So temperament assessment is extremely important in children, and the mood part, the emotional development is to some extent the continuation of temperamental characteristics. The mood can be cheerful, happy, irritable, gloomy. So here in adolescence, we see that there is emergence of negative emotionality. There's greater sensitivity to peer-related social interactions, and there's greater reward seeking, and all the basis of which I've already explained. So here, as the adolescence grows, so we have discussed that there's early adolescence, mid adolescence, and late adolescence. So about as the adolescence age progresses, so the adolescent starts to understand other emotions. They observe emotions as internal states. It's just not as what is apparent on the surface as a behavioral manifestation, but emotion is something that arises within an individual, and this is an internal state which will result in an external state in form of behavior. And then the individual is able to understand the influence of experiences outside of immediate relationships as they affect emotions. So a cause-effect relationship begins to be understood by the individual. Coming to the social development. Here, peers become very important, And teens is more a sociable age than the younger age. And adolescents often begin to identify with a particular group, and they're very sensitive to acceptance and rejection by peers. And here the romantic relationships emerge, and many a times it can be unstable, leading to mood fluctuations. So this combination makes the teen years a period of particularly high interpersonal stress. This is another important person by the name of Erickson, and he had theorized the psychosocial stages of development, right from birth till elderly, the age group, and he had divided the phases into different categories, and for people to, you know, deal with a specific age, to be able to deal with the demands of the specific age, when a person does that, it is then the other stage is successfully reached. So here he described the stage of adolescence as identity versus role confusion. So here the developmental task is self-observation, gaining more stable sense of self during the adolescence years. So it's about forming one's own identity that gives rise to forming the self-esteem. That is very important. Now, how do parental factors affect the adolescent behaviors? So these are the risk factors, particularly important when parents have these factors that would lead to behavioral disturbances. One is faulty communication, inconsistent parenting. The mother says something else, father would say something else. So you do well in your 10th board or 12th board, you'll get a phone or you'll get a laptop, and then when the child does well, they say no, we are not getting it now. Or very commonly, you do well, you get a pet. But when the exam is done, the child does well, no, you don't get a pet now. So that's false promises. And poor role modeling, as was discussed in the last uh, session. So we want our children not to use devices, but the parents will use devices during meal times, during times when they are free. And so how can the child learn? So because parents are the best role models, because these days the schools are not there, so the parents are the main role models for the children. Personality disorders in parents, so that's a risk factor. Family history of psychiatric disorders, because it's very important that coping is very important mechanism to deal with stresses. So how does a child learn coping? It is by seeing how parents react. Example, in this time of COVID, if parents get afraid, if they talk about COVID, the negative side of that, so the child will also think that it's something which is dreadful, and will start developing fear. So how to have positive coping and how to have positive problem solving skills, that the parents have to role model for the children to learn. Substance use in parents, very important. That's a big risk factor. Lack of time. So it is extremely important to spend good quality time with your children. Buying expensive toys with them doesn't matter. They can also play with cardboard boxes and be very happy, as happy as buying them an 8,000 truck or something, superhero. But so money doesn't come here at all. It's the time, and it's the quality time that you need to give to your child, and that's how you nourish the child. You take the child as a seedling and as a small plant, and then you have to put water, you have to put nutrients, and you have to give the adequate sunshine for the child to blossom and come into the world and deal with the world and deal effectively. So you have to give time. Critical parenting. very crucial, critical meaning. Why did you do this? Don't you know this much also? And look at your friends. They got more marks than you. Look at your sibling. She does so well. Why don't you work like that? So instead of praising the child, but with what he or she has, the strengths that he or she has, using criticism only damages the self-esteem. So that has to be avoided. And unduly increased expectations. So many of the time we have children and adolescents and who are academically so well, but because they're academically well, the parents want them to just come first and not even second, and to top in the board exams and to get into IIT or NEET. So, and this gives rise to anxiety, depression, suicidal ideations, lack of self-esteem, that I've not been able to meet my parents' expectation. What good I am? So these are all the parental factors that we need to keep in mind, and we have to be considerate. We have to be kind, and we have to let our children grow. And it is not that everything will work in the perfect way. If I have 5 fingers in my hand, no, they are not equal. So every child is different. Every child has got a different strength, a different capability, and I have to work on that. I can't expect magic out of a child. So that is not good. Mass media has been covered quite in detail in the last session, so I'll not discuss about this. But because of the level of immaturity in cognitive development, seeing content that is undesirable would lead to disturbances and would lead to distortion of reality. So that needs to be monitored by the parents. So my advice to parents would be, know and understand your child and use patience. That always works. Never get angry, never give criticism. In the previous session, Dr. Latika Balla said that once you write something on the social media, it stays there forever. Similarly, if we say something to our child, something negative, that stays in the child's mind forever. So always think before speaking something negative. Use patience and change your parenting from authoritative to friendly. We have to be friendly, especially with adolescents. So respecting their opinion, we have to seek their opinion, and that's how they feel cared for, and they feel they're loved, they feel they are important. Involve them in decision making. Open communication is very important, so that communication should not be just one-sided. Spend time, reward, set rules, and have a confiding relationship. So to conclude, so as I've discussed, that there are social, familial, cognitive, and biological characteristics in this period, and there's vulnerability factors that I have discussed, and the risk increases with maltreatment, and the resilience factors can be promoted by giving them a warm environment. With this, I complete my presentation. Thank you so much.
Amazing talk, Dr. Soumya. Amazing, very informative and lucid. And it was a whole new learning experience for me also. I learned a lot from your talk. So thanks to AOGD, Dr. Mala Srivastava and Dr. Anita for making me a part of this wonderful webinar. I heard all the lectures 1 to 4, and all of them were excellent. My respects to the chief guest, Dr. Achla, and the chief guest of honor, Dr. Gujral, and all my regards to my other co-chairs and wonderful speakers, whom I heard today. Coming to the topic, adolescence, we all know, is derived from the word adolescere, which means growing up. And if we make a narrow outlook, so it just means physical change and reproductive maturity. But I really congratulate the organizers that they have taken up everything the broader outlook, the psychological, social, and moral part of the adolescence. And the topic is also very good, nutrition and emotional health. So they are taking care of everything, a holistic approach to the adolescence. And we have heard all the speakers, they were wonderful. And one thing which is very, very important, I feel, is that we all know that the adolescents they are impulsive, they are temperamental, and they have a wide range of behavior. At times they are materialistic, they want everything which is there available all around, and at times they are very spiritual. Morally, we all know, we think that most of them are idealistic. Most of them, they want to do a lot of things for the world. They want to change the world also. So it gives us the opportunity to be a role model for them, which was very rightly said by Dr. Deepak also and Dr. Soumya also. So we need to have a good parenting for our adolescents, because there is always a conflict. We teach them moral, we teach them values, but we ourselves don't show the ideal behavior which we expect out of them. We find the world, they find the world conniving, cunning, and they see people who are very manipulative. They are succeeding in all the spheres. And of course, the media also plays the part. They find people attractive with wonderful bodies, known as successful people. So it all confuses them. So it's all, it needs a lot of discussion, a lot of workup. And I'm glad that we are taking one step, two steps further, and we are trying to do a lot for the adolescents. Thank you so much. Thank you.
Thank you. Thank you. May I add few things? Like,
Definitely.
Yeah. Thank you, Soumya, for such a nice presentation. Actually, it is a very important thing that we focus on the biology most of the time, and the biological changes in most of our workshops. Mental changes are really not taken up that seriously, and actually that is the most important thing for the adolescent that we need to consider and emphasize all the time. So a big thank you to Dr. Mala and Dr. Anita for taking this up, because what I am experiencing, I have been conducting these adolescent health workshops for the last 18 years, and since the time my girls were like born, and now they have, one has crossed adolescent and the other is going through adolescence. So as a mother, as a doctor, as a gynecologist, we see and kind of things, like all kinds of things and all kind of behavior abnormalities that lead to biological as well as hormonal disturbances in adolescent. The important thing which about the pruning thing which you told is that this is the second phase, like second opportunity for us to invest. Like one is the early, like when they're infant up to 2-3 years, that this adolescents give us the second opportunity for us to invest in their mental health as well as in their nutritional and biological needs. So it is very important for all of us to focus on this, because as Anita and me had we had gone through the same workshop, and I guess Anita coined this that na ye chote hai na bade, badi mushkil mein hai pade. So neither they are like kids nor they are adolescent, and nobody's like really focusing on them in spite of so many clinics coming up. So that is my point. And second thing is that what I'm experiencing is that is unhealed parents are bringing unhealed kids. So धूल चेहरे पे है, आईना साफ करते रहे. So we are ourselves not really mature people to, because there were no books in parenting, we are bringing up, we are comparing our own lives with others, and that is giving undue pressure on the adolescent. So this is my take on it, that we have to be, of course, the role models in everything, like not actually just the dresses or the cars, but the morality and the spirituality which we practice is actually imbibed by them, in spite of what we keep telling them. If we don't practice the same things, then it's other. That's my take on it. And thank you for inviting me to share the session. It's a pleasure. All the lectures were wonderful.
I have also one point. Thank you. Congratulations, Dr. Soumya, for such sensitivity. You have, discussed the child psychology, the adolescent psychology. I think this is the need of the hour. This past 2 years, the COVID has really done very bad effect on the adolescent psychology. And my request to Mala ma'am and Dr. Anita ma'am is that we should do more and more these kind of, focusing more on the mental health.
Yes,
of course, we have to listen to the children. For the past 2 years, they're sitting in one room, they're logging on to the classrooms, they are switching off the cameras, and they are just sitting. Just think of their, the mental condition, how they are coping up. So this has to be a national program for the child psychology, adolescent psychology. Very good. Congratulations for such a wonderful topic.
It was. One question.
Yes.
Excuse me. One question.
Yes, ma'am. Yes, ma'am. Please go
One
ahead.
question from Dr. Soumya. Dr. Soumya, you talked about synaptic pruning.
Yeah.
I mean, what you meant was, what I could gather was that if you don't develop one thing in the child, so that part of the brain doesn't function, or that part of the, what do you say, skill, that doesn't come out, or what was that? I couldn't understand that word.
It's, ma'am, it's not about the part of the brain, but it's about the synapses. Developmentally, what a child is born is with excessive, it's like having the ovarian follicles that gradually diminish with age. So as a child is born, there are excessive
neurons
that are really not required in the long term. So as a part of the normal development, there is synaptic pruning. But the networks, it's regarding the neural networks, which are used more, they stay, but which are not used, they dissolve. So this is also the basis for certain psychiatric disorders like schizophrenia, and which is also seen to occur in adolescents because there is excessive synaptic pruning, what is more than required. So it's not about the brain area, but it's about the synapses, some neural pathways.
Okay.
Yeah,
Thank
there
you.
is, there is plenty actually. 2 days back only I conducted a workshop, so I read a lot about pruning and the connections and how the myelination changes in the adolescent. So basically, as a gynecologist, we are reading more about the biological changes, less about the mental changes. It's always enlightening to know more about it actually. So
yes,
that's it.
Very true, very true. They say that a human being is using only 1 or 2% of neurons during their lifetime. So with advancing age, they say if you do mental exercises, brain exercises, for doing puzzles, they open new synapses, as already highlighted by Dr. Soumya. Congratulations, Soumya. And Aradhana has also brought out a very valid point that sitting in a closed room and in a closed environment, not able to go to school or to play, it becomes like a havoc on the psychology of the child. I'll narrate a story that my son came from his college and he asked, actually he just met my maid's son on the way. While he was climbing upstairs, he said, "Beta, which school do you go to?" Kehta, what is the fun of knowing my school's name and I'm not going there for last 2 years? I don't want to tell you. And the psychology of the child that he must be facing. He said this. So definitely, all these things are making an impact of life of children more.
We can't blame children for these 2 years. We can't blame them that they're using so much of media. It has to be there. Now we have to find out the solutions of it.
Exactly. You're right on that.
As the COVID goes down, I think everything will become better.
Yes.
Like Dr. Deepak
Actually, everything is not on COVID also.
Yes,
without COVID
I'm so
also,
happy.
Yes,
I'm so happy that everybody has enjoyed and liked the session, the topics, because these are very relevant topics in the day-to-day practice.
There is one question from Dr. Subir Majumdar: how to limit intake of spicy and fried food in adolescent in the current scenario? Because this is the age where peer pressure and personal choices override the parental guidance. So anybody will like to, talk about these food addictions?
See, basically, you have to inculcate in the children home food.
Yeah,
घर का
I
खाना.
tell them, yeah, so take them along with you to make spicy things together. Like makhana can be given instead of cracks. So I fry like makhana and I tell them to eat. So you can have alternative, healthy and good spice.
I think Dr. Soumya would agree that I know that if you are eating the chips, that it's not that taste and that crunch gives more stimulation to the brain to eat more.
Yeah,
That
so you can
crunchy
teach
feeling.
them, yeah.
So
Teach them
we
to
have
make
to,
crunchy
yeah.
things like makhana and murmura and things like that, which we used to eat in our
But yeah, we can
time.
replace those potato chips
Replace
with
and
healthier
teach them, yeah, involve them in the kitchen with that.
Basically, we have to come up with the options to the kids. If not this,
Yeah.
then what? If not a
Yes.
screen, then what? They're asking you, then what do I do? So we have to come up with the options for them.
Actually,
Healthy
fast food
hobbies.
these kind of foods are easily available, approachable. So means children get addicted to those because making healthy food is a bit it takes effort on the parents' part.
Parents also, yes.
If madam, if you all will agree, in our age of adolescence, we have not heard of anxiety, depression, addiction. We have not heard these words.
Very true. Very true.
And now,
But yeah, here one point I would like to say, doctor, because it was not that there was no anxiety or no depression in our times. It was just that we never used to come out with that. So that is why I'm saying unhealed parents are giving rise to unhealed children. है ना? हम उसको एक्सेप्ट ही नहीं करते कि हम कभी डिप्रेस हुए होंगे या हमारे एंजाइटी इश्यूज हैं. So
they were not addressed.
Yeah, they were not
Probably
addressed.
for parents is to give us more time, Dr. Subbuhi. And these time the parents are so busy in themselves that they don't find time for the children. This is also one of a very important.
Yeah, it is one of the factors. It is one of the factors, but yeah, we are also not actually.
I
doing our-
believe
our
that they
own
are more
personality.
Equally responsible for it.
I
Yeah.
believe today's adolescents are more exposed to all these things and all the informations about these things. We were not that informed.
That time we had nothing. Neither TV was not that much popular also.
Yeah.
Right.
Every house they never had TV. Now to everywhere.
Every
So,
room, ma'am.
any
Every
socio-economic
room.
strata, they have mobiles and TV.
Okay, so
That's
goodbye
true.
from me. I have to give time to my adolescent now.
Thank you. Now it is time for me to propose formal vote of thanks to all my dear faculty and all the delegates. Thank you, Dr. Mala Srivastava, for partnering with Adolescent Health Committee. Thank you so much for coming up with this good idea. And I'm really thankful to Achla ma'am and Gujral ma'am for gracing the occasion. And I'm again thankful to ICOG for giving us 2 credit points. My regards to Dr. Uday Thanewala, Parag sir, and Ashok Kumar sir. And I'm really thankful to my learned chairpersons, Dr. Kiran Arora, Dr. Deepa Mukhanandan, Dr. Manisha Ghate, Dr. Amita Gupta, Dr. Suman Sinha, Dr. Chanchal, Dr. Latika Bhalla, Dr. Shweta Mathur, respected Neeraj Yadav sir, my dear Aradhana, Amrita ma'am, thank you all for coming and joining us. Thank you Subbuhi for gracing the occasion. I'm really thankful to all the chairpersons and for their excellent inputs. And my gratitude goes to all the speakers. They have done wonderful job. Dr. Shweta Gupta, Dr. Kanchan Sodhi, Dr. Deepak Gupta, and of course, Dr. Soumya. Wonderful presentations. It was a pleasure. It was a learning experience for all of us. And I'm really thankful to my Master of Ceremony, dear Dr. Renuka and Ankita Srivastava. Thank you so much. And above all, thank you to all dear delegates who joined us on their busy day today. Thanks for joining. Hope it was a learning experience for all of us and we all gained out of this. And my sincere thanks to Dr. Deepika Chhabra for giving us the platform to work, and we'll keep on working with you, dear Deepika. Thank you for providing us this platform.
Thank you so
Best
much,
of
everyone,
luck.
and good night.
Thank you.
Best of luck
you.
to
Good night.
Mala and
Best
Dr.
of luck,
Anita.
Anita ma'am.
Thank you, thank you.
Bye-bye. Thank you.
And my appeal for Dr. Sadhna Gupta, ma'am.
And Dr.
Yes, and
Suman also,
please
she's
do
also
help us.
Yes,
continuously.
ma'am. Dr. Suman.
Dr. Mala and Dr. Anita both
Yes.
Dr. Bala, Dr. Anita, Dr. Suman,
And
Dr. Manisha.
and
And
Dr.
my,
Manisha Ghate.
my appeal for Dr. Sadhana
Dr.
Gupta.
Sadhana Gupta.
Indirectly.
Sure. Best wishes
Definitely,
to all of you.
definitely.
Thank you.
Thanks,
For
thanks,
sure.
and good night.
Thank you, everybody, for
Good
joining.
night.
Bye-bye.
Thank you. Good night.
Bye bye.
Thank you
Good
very
night.
much
Bye.
from Jagsonpal, the makers of LycoRed, the cell protector.
Thank you.
And maximum webinars.
Thank you so much. And we are really pleased to be associating with all of you. There's another product by the name Cystelia-M, which is myoinositol and D-chiroinositol with L-methyl folate and vitamin D3, 1000 IU. So give us your support for our products too. And we look forward to your presence again. Tomorrow, we have a DGF President Oration tomorrow. Do join us on this Zoom ID. And we look forward to meeting you again.